Good evening and a very warm welcome to the 3M Scientific Symposium. My name is Vicky Murray and I'm the Scientific Affairs Manager for 3M Medical Solutions Division. And I'm also very proud to be an industry trustee for the Tissue Viability Society. So this symposium is titled The Challenges of Maintaining Skin Integrity in the Older Person. And we have three fantastic speakers for you tonight. We have Professor Dimitri Beeckman, Laura Browne and Heidi Sandoz. So Heidi is going to be our chair this evening, and I'll just give you a quick overview, which is a really impressive career that Heidi has in tissue viability. So Heidi is a part-time tissue viability services lead for Hertfordshire Community NHS Trust, and also works in private consultancy. She's currently on the steering group for the National Wound Care Programme for Surgical Wounds and also Pressure Ulcer Group. She is the past chair for our Tissue Viability Society and also honorary lecturer at the University of Hertfordshire. And very excitingly, Heidi is our educator for the TVS Skincare Champions programme. Heidi's very passionate about education. She's also very passionate about improving services for patients and also about team development. So with that, we'll hand over to Heidi, and thank you very much, Heidi.
Thank you, Vicky. That's all very kind of you. So welcome everybody to this 3M symposium. I'd like to thank 3M for inviting myself and my fellow colleagues to come and speak on this symposium and for putting it on for everybody. Maintaining integrity in the older person is a very complex mission for all of us. And this session is not going to spend much time on pressure ulcers, but it will be looking at some of the other prevalent wound types and issues that we see, particularly moisture associated skin damage, which will include intertrigo, skin tears, and it will also consider pathways and education of carers, healthcare professionals to improve skin chances of maintaining integrity. So if you have any questions that you want to pop in, you can use the Q&A box at the bottom there, or you can use the chat. I think you're all muted, so I don't think it will be an issue if a child comes running in or a dog starts barking for anybody. So we've all got used to this over the last year. So very unfortunately, our first speaker tonight, Dimitri Beeckman, could not be with us this evening, and he will introduce himself in his presentation, which is pre-recorded, so I'm not going to do that any further here. And he will be followed by Laura Browne, who is an operational lead for the Tissue Viability Service in Leicestershire Partnership Trust. Laura has the responsibility of managing a team of 9 tissue viability nurses, which cover Leicestershire County and also Rutland, and leads the Leicester City Wound Clinic service, in which they run 10 general wound care and leg ulcer clinics across the city. Laura has a specialist interest and enhanced knowledge in the prevention, management and treatment of MASD, and will share with us some of the challenges of delivering effective skincare in the community and how they have addressed this in her area. And then finally, I'm going to be presenting on the challenges in providing skin and wound care education in the social care sector. I'll be pulling on some of the literature about that, but also some of our personal experience in TVS with our Skincare Champions education programme. So without further ado, I think we'll hand over to Dimitri, and if I could ask the team to start Dimitri's presentation. Thank you.
Hi everyone, I'm Dimitri Beeckman. I'm a professor of nursing science at Ghent University in Belgium and Örebro University in Sweden. I'm the current president of the International Skin Care Advisory Panel and European Pressure Ulcer Advisory Panel. So I'm invited today to present about recent evidence and best practice guidelines on moisture-associated skin damage, with a specific focus on incontinence-associated dermatitis and intertriginous dermatitis. I would like to thank 3M for inviting me today to share this best practice recommendations. So we will start with a presentation about the concept. So what is moisture-associated skin damage? MASD, that's the abbreviation, is classified as irritant contact dermatitis. It is actually an umbrella term, subdivided into 4 main different types: incontinence-associated dermatitis, or IAD, peristomal dermatitis, intertriginous dermatitis or intertrigo, and peri-wound maceration. All those 4 skin damages are attributable to a range of different factors, and I will present them today. So I try to categorize them just to give you some first insights. It's about the moisture source, specifically the chemical irritants within the moisture source. It's the pH, it's the associated microorganisms on the skin surface, and a range of what we call mechanical factors, such as, for example, friction, but also pressure and shearing. What is of key importance in those 4 different etiologies? It's risk assessment, the application of preventative strategies, and the main focus of today is on how to protect the skin. So let's start with incontinence-associated dermatitis. What is IED? IED is actually skin damage, which is associated specifically with the exposure of the skin to urine, stool, or a combination of urine and stool. We need to consider liquid stool, being diarrhea, as the major contributor to IED development. We have to realize that it can affect more than only the perineal area. It can affect people of any age, and it has a detrimental effect on the patient's quality of life, and it will impact the comfort levels. Research, not that much research, but from our clinical experience as well, we know that it provides or causes physical and mental distress. It's time consuming, it's difficult, and sometimes expensive as well to manage in our clinical practice. On this slide, you can see a code. It says ICD 11EK02.022. So please don't try to remember this coding. This is just there because since 2018, IED has a specific coding in the International Classification of Diseases. So this is a major step forwards in our definition and recognition as IED as a medical condition. And on the right-hand side of this slide, you can see a clinical picture of an IED lesion with an additional fungal infection. Important is how do we identify and how do we manage the risk? I'm just going to share you some best practice statements. We have to focus on the cause, causal factors, indirect factors, and contextual factors. Causal factors are the presence of incontinence, being urine and or stool. And as I mentioned before, mainly liquid stool is one of the major problems. Indirect factors, such as, for example, the age of the patient, the nutritional status, the presence of diabetes. So they all will contribute to the development if the causal factor is present. And it is vital to recognize patients at increased risk. And I think that is quite clear why, because we need to be able to implement preventative strategies as soon as possible. So for that, we need accurate risk assessment and also a classification tool. And today in this presentation, I will update you as well about a classification tool. On this slide, you can see a list of causal factors and indirect factors. And again, this is a summary of what I presented before. It's the type of the incontinence, solid stool versus liquid stool, and of course, urine or the combination of urine and feces. And then there is a long list of different indirect factors. For example, diapers, the exposure time, the frequency and the volume, drugs in urine and stool, mechanical forces, etc., etc. So I'm not going to read them all. I would like you to read our best practice statement documents on that, and to remember that we always have to make a difference between a causal factor and an indirect factor. So then we move into the IED management. First of all, we have to identify and we have to treat the cause of the incontinence. Indirect factors should be mitigated, and we need to apply a regular reassessment of the type of and frequency of IED and incontinence. We have to tailor our incontinence management strategy to the individual and to assess the risk for skin-related damage. And in this regard, I'm really arguing for the importance of doing this in an interdisciplinary context, where continence specialists collaborate with skin care specialists. So at the level of the local treatments, some best practice statements: skin cleansing. So use a skin cleanser with a mild surfactant and consider cleansing techniques that are gentle to the skin. A major recommendation is at all times avoid the use of soap and water washing, because soap will increase the skin pH, and the higher the skin pH, the more the risk for bacterial infections, and the more the impact on the barrier function will be. So that's at the level of cleansing. At the level of protection, we made the difference between patients with IED and patients at risk for IED. So in patients with IED, we need to apply a skin protector that can alleviate pain and, of course, improve the comfort of the patients. For patients at risk of IED, we need to focus on protection by repelling the moisture and the irritants from the skin. IED classification and documentation, I did not mention this before, but research clearly points out the relationship between incontinence-associated dermatitis, its most important etiological factors being incontinence and pressure ulcer development. So we need to recognize the association between pressure ulcers and IED. We also realize that it's a challenge in clinical practice to identify IED and pressure ulcers. So that's why I tried to summarize the different parameters that you can apply in your clinical practice to make that differential diagnosis. So consider the history, the symptoms, the location, the shape and the edges of the lesion, the presentation of the defect itself and the depth, and the presence of infection. So I'm not going to read this. I, again, would like to refer to our documents that we published in 2015. We also made updates in 2018 and 2021. So please have a look at those documents to learn more about the differential diagnosis. In terms of classification, since 2017-18, we have the availability of the Ghent global IED categorization tool. So because we were lacking a consistent language and terminology. So that's why we developed and we introduced the Ghent global IED categorization tool. And this is how the tool looks like. We identified two main categories. Category 1 is the persistent redness, and category 2 is the presence of skin loss. And then we subdivided those two categories into an A and a B. So category 1A is persistent redness without any clinical signs of infection. Category 1B, on the other hand, is persistent redness, but with clinical signs of infection. And then as from the moment that you observe skin loss, we will categorize this as a category 2. Category 2A means skin loss without any clinical signs of infection, and a 2B means skin loss with clinical signs of infection. So it actually includes 4 different categories, 1 and 2, and then subdivided this in the A and the B. So the second condition I would like to discuss today is ITD, or intertriginous dermatitis. So it is also covered by the moisture-associated skin damage, but it has a different nature. So this is caused by the accumulation of sweat in combination with friction, mainly under the large skin folds. So those skin folds include the breasts, the lower abdomen, the groin, also between the digits in the perineal area. And what we can observe clinically is erythema, crusting, it's very typical, and maceration. It's also associated with the presence of fungal infection and bacterial overgrowth. So in intertriginous dermatitis, the fungal problem is much more present than it is in incontinence-associated dermatitis, mainly because of the frictional components and the area, for example, under the large skin folds. What are specific risk factors? Well, of course, hyperhidrosis, so a lot of sweating, immunodeficiency, diabetes, immobility, again, large skin folds, and of course, obesity. What are the high risk groups? Always consider patients that are obese or post-bariatric surgical patients to be at increased risk for ITD development. For ITD, we don't have a formal standardized risk assessment. Our prevention program focuses on, multiple components, weight loss programs, skin fold hygiene programs, and of course, just as we had in IAD, early detection and treatment of the first signs of ITD development. The diagnosis depends upon the intersection of risk factors, and what is very typical is redness and the inflamed skin, and in some cases, the presence of infection. What are clinical signs? Well, we've got very often a mirror image of the erythema in the skin folds. Itching, stinging, and burning are reported very frequently by patients. What's the major problem in ITD? That's bacterial load and the presence of a secondary infection. So intense itching, inflamed areas, satellite lesions showing the presence of a secondary infection. We also call them fiery red lesions. Exudate is increasing, odor starts occurring. These are clinical signs of the presence of a bacterial infection. And please always remember that ITD can even progress into more serious tissue destruction. So timely prevention and appropriate treatment are of utmost importance. So the assessment of the bacterial load includes two components: the assessment of the skin, and of course, the monitoring of the odor. So what do we recommend in our best practice statements? We have to maximize the intrinsic moisture barrier function of the skin. As in every MASD type, the moisture barrier of the skin, the function of the skin, is actually one of the contributors to the development of the condition. So we recommend to minimize skin-on-skin contact and friction. We recommend the removal of irritants as soon as possible to protect the skin from additional exposure. We also recommend to wick away the moisture from the affected and the at-risk skin by controlling and diverting the moisture source, and of course the prevention of secondary infection. A skincare regimen, avoiding drying agents, patient education such as skin fold management, supportive garments, loose fitting, natural fabrics. So these are all in our basket when it comes to prevention and treatment of ITD. We would like to stress the importance of maintaining good practice around hygiene, moisture wicking fabrics to absorb the moisture, but also to support the evaporation of moisture from the at-risk area. And then, of course, the application of protecting skincare products. Always rule out the presence of infection. And then not covered under the area of condition of MASD is skin tearing. Skin tearing is actually a traumatic wound, and a wound that is caused by a mechanical force. So in the previous two examples, the wounds were caused by the presence of moisture in combination with friction sometimes, but here in skin tears, the cause is the mechanical force. And that also includes the removal of adhesives. They can vary by depth, but they will never extend through the subcutaneous layer. They are reported in all healthcare settings, and they're particularly common in the upper and the lower extremities. 50 to 80% of the lesions occur in the upper extremities and 15 to 60% in the lower extremities. So what do we know about the etiology? Well, it's actually caused by a variety of different mechanical forces: shearing, friction, including blunt trauma, poor positioning, transferring techniques, equipment injuries, adherent and sticky dressings. So when removing them or lifting them, we might cause the skin to be damaged of the epidermis from the dermis. So that means if it remains superficial, we will call them partial thickness wounds. But if both the epidermis and the dermis are separated from the underlying structure, full thickness wounds. So they can actually be present in those two types: partial thickness, epidermis separated from the dermis, and then epidermis and dermis separated from the underlying structure. So that means a full thickness wound. Why is age related to the presence of, or the existence, the development of skin tears? Well, we know that in our older patient population, the skin quality, the skin functioning, the barrier function is compromised. There are multiple reasons. There is a loss of collagen and elastin. We can see a reduced thickness of the epidermal layer. We can see the loss of the dermal and the subcutaneous tissue, a reduced proliferation of keratinocytes, and longer turnover time in the epidermis. We also can see that the dermo-epidermal junction is actually flattening, and that means that the skin gets more damaged easily. Natural moisturizing factor is lower, so the NMF, lipids in the stratum corneum, they decrease. Sweat and sebum production are decreased. So there are multiple arguments and reasons why our older population is at higher risk. For skin tears, we've got multiple classification tools. One of the tools is the one by the International Skin Tear Advisory. On the right-hand side, you can see the classification tool. Type 1, Type 2, Type 3. Type 1 is no skin loss. It's a linear lesion. A Type 2 is partial flap loss. So part of the flap can still be repositioned to cover the wound bed. And a Type 3 is full, total flap loss. So that means the wound bed is fully exposed. So there is no flap to cover the exposed wound bed. This classification instrument has been studied extensively. So very recently, we published a paper in which we report a study where we evaluated the psychometric testing of the ISTEP classification system in 44 countries. So that's on the left-hand side. And then another paper where we made an evaluation and assessment of all the measurement properties of existing classification systems or tools, and we performed a systematic review. So this is, I think, very interesting further reading if you want to learn more about classification. So then we move into the prevention. As with MISD, it's about the multidisciplinary team approach. We have to empower patients. We have to empower our family, caregivers. So they all need to contribute actively to prevention. So this is not rocket science. This is something that happens in our day-to-day care. Okay, so empowering everyone who is involved in the development and the treatment and the prevention of these lesions is important. Very important is the application of dressings, skin-friendly dressings and skin-friendly removal techniques. Silicone dressings, so with the top layer of silicone, foam dressings, so they're more gentle to the skin, both upon the application, but also upon the removal. Glide sheets, protective clothing, padding, fall prevention, avoiding sharp fingernails and jewelry. I think that these are all the basics of a proper preventative approach. And you can see on the picture some examples on how to do that in your clinical practice. So what do we know about treatments? The International Skin Tear Advisory Panel developed a pathway from assessment to cleansing to approximation of the wound edges. And it's only at that specific point in time that you can start classifying and measuring and documenting the skin tear. So remember that I presented the three types. So the assessment and the classification should only be done after cleansing and approximating the wound edges. So on this slide, you can see the pathway from 1 to 5. What we like to recommend is the use of very gentle techniques. Avoid the use of forceps to lift and to reposition, approximate the wound edges, because there is always a risk for damaging the skin flap. So that's why we recommend the use of a cotton wool stick to lift the flap and to position the flap on the right place. So you can see we start with quite an open wound in one. You could have thought that this is a type 3 skin tear, but in the end, after approximating the wound edges, it is actually classified as a type 1 skin tear. And this is a good example. So the left picture is before the approximation of the wound edges or the skin flap. And the second picture is just after approximation. And you can see that it is actually a linear lesion, which means that it is a type 1 skin tear. So for treatment, do not add additional new risk for trauma. Assess comorbidities, for example, venous disease, arterial disease, pressure, etc., and select a dressing that includes those 4 different characteristics. Decreasing trauma, both on application, reapplication, and removal. The dressing should be able to provide you with a moist wound healing, managing pain, and allow wound observation as much as possible. So the more the dressing can be transparent, the better it will be to check and evaluate the skin. So I mentioned the word skin flap before. A skin flap is actually a natural dressing. So the more we can use of the skin flap to cover the wound bed, the better. But if the skin flap is not viable, it's actually dead tissue, it may need to be removed or debrided. But please, care should be taken during the removal to ensure that the viable skin flap is left intact and that the fragile skin is protected. Okay, so if the skin flap is viable, please try to use it as maximally as possible to cover the wound bed. We also recommend and stress the importance of distinguishing normal wound inflammation that is associated with trauma and wound infection. If there is wound infection, that can result in pain, in a delayed wound healing, and the diagnosis of the infection should be based on the clinical assessments. On the right-hand side, you can see an example of an inflamed, quite normal skin tear. And on the bottom, you can see the infected skin tear. So of course, that requires a different approach than the one that is inflamed. What we also recommend is the importance of carefully removing the dressing. So we recommend that you indicate on how to remove the dressing, because underneath there is a skin flap, which is very, very fragile. And we want to keep the skin flap as intact as possible. There is always a risk when you lift and remove the dressing that you damage the skin flap. So that's why it's good to indicate on how to remove the dressing to avoid additional trauma. So we discussed about the aging population. There is an increased prevalence of chronic diseases, MASD, and skin tears. They are expected to remain a common health problem with a significant burden on the healthcare system, but even more importantly, on our individual patients. We discussed about MASD, and I clarified that we divide them into 4 main categories: incontinence associated, sweat, perspiration associated, liquids associated with stoma, and the peri-wound skin damage. Skin tears, they are divided into 3 types, from type 1 to type 3, from a linear lesion to a lesion where the entire wound bed is exposed. It's not only the moisture, but also friction and the chemical composition of the bodily fluids and the occlusion that will contribute to the development of these skin conditions. Risk assessment, prevention of mitigating factors, employing an appropriate and a structured care regimen, considering appropriate dressings, skin protection by applying barrier products is of utmost importance to provide that proper high quality care. And my final point for this presentation is standardization and documentation, because this is really of key importance for data collection, but also to guide your own care, your future care and research. And at the bottom of this slide, I just included our latest best practice documents, one published in 2018, specifically on prevention and management of skin tears in the aged skin. And then a very recent one from last year, 2020, where we focused on a more holistic strategy to promote and to maintain skin integrity. So these are my contact details. I would like to thank you for participating in this session organized by 3M. And I would like to wish you all the best for the future in your clinical practice. Thank you very much.
So thanks to Dimitri for that. Now, if any of you have any questions for Dimitri, he's not able to be here today, but do pop them in the chat, and we are advised by him that we can pass them on to him and he will respond to those questions and we'll get those responses back to you. So without further ado, I've already given an intro to Laura. I'm going to hand over to Laura so that she can share her screen now and go through her presentation. Thank you, Laura.
Hello, good evening. Thanks for inviting me to this evening to talk about some of the challenges that we see in caring for the older person's skin in the community. So I'm with you for the next 10 minutes. So one of the first challenges, as we know, the skin naturally declines with age. So it becomes thinner, flatter, loses its elasticity, it can dry out, and it puts it more an increased risk of developing trauma injury, things like moisture damage, pressure ulcers, skin tears. The skin acts as protection, as we know as well, and it's the first line of defence against environmental hazards and contamination. But in order to act as an effective barrier, it needs to remain intact. As we age as well, the skin is constantly being affected by these external factors like water, air, the sun, and the products that we use. And it's all of which are going to affect that integrity. Some of the commercially available products that patient uses as well to naturally change that skin's pH level, stripping it of its acid mantle. And that acid mantle inhibits the growth of bacteria, which can easily lead to things like wound infection. So it can be really challenging practice to steer patients away from some of these commercially available products that they've used for all their lives. You know, sometimes it can just be habit, or it can be quick and convenient to use, or it could be just because they like the smell and it's something they're used to and it makes them feel clean. It can be really challenging to provide guidance and education on this and steer them in the right direction, but it just makes our job so important, and the advice we give so important in providing that rationale to patients on what they're using for their skin. Some of the other challenges is we have an aging population, and they've got increased complex comorbidities that we're dealing with, many of which have a direct or indirect impact on the patient's skin. So it's really important that we look at our patients holistically and ensure that we're considering all these challenges when implementing any sort of care plan with our patient, because that's going to affect how effective it's implemented into that patient's life. We're seeing patients with complex mental health issues, you know, patients that are suffering with self-neglect, they're on medications perhaps that are making them drowsy, that's affecting concordance and motivation. A lot of our elderly patients as well are suffering with incontinence, reduced mobility. They're perhaps on medications that thin the skin, or non-steroidal anti-inflammatories that infect healing. Lots of different challenges that are affecting our patients. So I said it's really important to understand these challenges and make sure that we're doing a holistic assessment of those patients' needs. So some of the priorities that we're concentrating on in our community trust is reducing the prevalence of moisture-associated skin damage, but also pressure ulcers. And as we know, there's a direct link between these two things, because if that skin's integrity is affected, it's going to naturally put that patient at increased risk of developing pressure damage. Some of the other key learning that we've captured as an organisation is we need to improve the education that we provide to patients and care staff, and really put the patient at the heart of all we do, and making sure that they, you know, the care plan is agreed with them, it's realistic, it fits in with their daily lives, and it's personalised to their needs, and of course communicated then to all those people involved in that patient's care. We were seeing as well an increase in referrals coming from domiciliary care agencies, but also residential homes for patients who developed a skin tear. And of course, this meant an unplanned visit from the nursing team, additional pressure, but also, you know, we weren't able to provide that direct first aid care for our patients, which of course could affect healing in the long term. So we developed a skincare pathway, and it was just a visual tool that we could circulate to carers, and it provided some guidance around prevention of skin tears, but also what they could do within their competency to provide that direct care for the patient, whether it was just simply relaying the flap over the wound and covering it to reduce the risk of infection. And that could make the difference between that wound being an acute wound to becoming a chronic wound further down the line. We also wanted to focus on the skincare we were providing our patients. So in the next couple of slides, I'm going to talk about the moisture-associated skincare guidelines that we developed for patients, because skincare is at the heart of that prevention and treatment of these kind of conditions. So prior to the implementation of the guidelines, we had a lack of standardised practice, you know, a lack of standardised products that we were using. We were seeing inappropriate reporting, you know, pressure ulcers that were in fact moisture damage. And if we're getting that diagnosis wrong, then we're getting that treatment also wrong for our patients, which could obviously affect patient outcomes. So we needed a single point of reference for this evidence-based practice, for that best practice that Dimitri talked about, that staff could access and use to support them in practice. So when we developed the guidance, we incorporated the importance of a holistic assessment, but also the importance of that diagnosis. So we provided guidance on what's a pressure ulcer, what's a moisture lesion, but also considered those other skincare conditions that we also see a lot in the community. In fact, anywhere like eczema, psoriasis, simple things like fungal infection as well, and what we could do in practice to not only prevent them, but also what we could do to manage and treat those issues. So when we implemented the guidance, we automatically saw an improvement in knowledge of staff as well. We were seeing that through the documentation. We were seeing that they were making prompt referrals to specialist services such as tissue viability or continence. And we were able to use these guidance as a single point of reference to guide staff on what they should be implementing. And we were also then able to incorporate that guidance into our training programs, not only internally for nursing staff, but also incorporate it within our training programs for carers as well, domiciliary and residential homes. So it made a big difference, a big improvement in patient care. Alongside that, we developed a skin excoriation tool as well, a visual aid. This is something that we adapted from a tool used in Scotland, and we adopted that traffic light approach, a visual tool and aid that staff could have within their clinic setting, hospital ward or community base as a guide to support them on the advice that they should be providing, not only from prevention of healthy skin, but all the way through to severe excoriation. So a nice simple tool that they could use. We more recently as well devised a care plan for carers, because as we know, another challenge is continuity of care. There's such a fast turnover of staff in nursing care, but also within social care. So we couldn't guarantee that the advice that we were providing to that patient or the carer that was there was going to be followed through. And that is so vitally important. So we developed this care plan for carers. It could remain within the patient's homes, and we could give guidance on what we were advising to cleanse the skin with, to protect the skin with, and if it needed hydrating, we could include that step as well. And within that care plan, we had a comments section. So if the carers were struggling or had any concerns, they could document on that. And when we did that nursing visit, we could review that and hopefully resolve their concerns. So as we know, with anything that we implement, there's always further learning and recommendations that we can make. So we're trying to improve the access to resources, not only for our nursing staff, or our carers. So we're developing a tissue viability app as a single point of reference for our nurses to these tools. We're also developing a carer page as well. So carers have access to things like repositioning charts, to the skincare pathway that I talked about as well. So again, in this agile world, people have those resources at the touch of a finger. We want to develop a moisture-associated skincare pathway to encompass all those products that we use. And we've been lucky enough to have the skincare advanced skin protectant on our formulary now. We tend to use it for moderate and severe excoriation. So incorporating that into the pathway and providing rationale for its use. So we're having lots of quality improvement projects that we're focusing on at the moment. And we're really trying to work in collaboration with wider services and ensure their involvement and expertise is taken on board, but also engaging with patients and carers on these things. And we've been lucky enough to start to build a care and patient education forum so that we can show the patients and carers these tools and make sure that they're in the right format and they're fit for purpose, when of course they're the ones that are going to be using them. So if you want any advice regarding any of the projects that I've implemented or the future products or the skincare guidelines, I know that my email is going to be circulated. So feel free to drop me a line if you have any questions. But I'd like to thank you for listening this evening, and I hope you've enjoyed your day.
Thank you, Laura. If I could ask you to stop sharing your screen, thank you. That was really interesting. Really great to hear Dimitri tell us what's best practice, and then really great to hear how you've managed to implement that in your local area. I do confess to feeling quite envious of your service and what you've been able to achieve. So thank you very much. So I think as we're pressed for time, I'm going to go straight into my presentation and try and keep that to time as well. So I'm going to be covering the challenges that we experience in providing skin and wound care education in the social care sector. Just a declaration slide there that I've been asked to include. So when we're talking about the social care sector, who exactly are we referring to? So adult carers can be employed as a personal assistant, they can be employed as a domiciliary carer or within a residential or nursing care home. They might also be employed in daycare centres and other establishments. And you can see from the statistics on this slide that actually the reach is quite large. The key documents that I do refer to in this presentation do highlight data from England. So when we include Northern Ireland, Wales and Scotland, then the reach is much, much bigger than the numbers that I'm including here. So what we know is that there are 18,200 provider organisations who provide 38,000 establishments and employ 1.16 million whole-time equivalent roles in those services. And you can see from the chart bottom left that the organisation size can vary, with 38% only employing 1 to 4 staff members. The large portion of care is delivered in non-residential settings. So that is to say, not in a care home. So what does this workforce look like? Well, there's 1.65 million adult social care jobs with 1.52 million people working in those roles. The circles to the right there show how the different staffing roles are made up within that. So you can see that in some of these there are registered professionals included in that. And in addition, we've got 135,000 personal assistants who are directly employed by the person who's wanting their care. 82% of this workforce are female, with 91% being aged over 25. And you can see that 27% are aged over 55. Interestingly, though, despite only 18% of the workforce being male, 33% of the senior manager roles are actually filled by males. So it's very clear from the slide previously that there were fewer staff in post than there are jobs. Staff vacancy rates are quite high at 7.3%, although when we compare that to registered nursing vacancy rates in the NHS, they're at 10.3%. And they are both, again, higher for managers. The turnover of staff is at 30.4%, with the highest levels being seen in those who have less than 1 year experience. And Rob Webster, who spoke this morning at one of the sessions this morning, late morning, also highlighted some of that in his answers following his talk. So staff come in, but they don't necessarily stay. And having seen a decline in funding in the first half of the last decade, as you can see from the slide there to the right, the diagram to the right there, we've now returned to similar levels that we were at a decade ago. Now, I'm no accountant, but to me, that looks like a funding cut. So there are also some challenges around the employment of these staff. 89% of them are on permanent contracts. However, 58% are on 0 hour. So they'll only get paid for what they work. If they take leave, they don't get paid for that. And the split between full and part-time staff is actually 50-50. But the chart at the bottom right there actually compares what a care worker might earn versus somebody in another industry, such as sales, retail and cleaning. And you can see that in 2012-13, carers were at the upper end of that wage, but now they're not necessarily, that's not necessarily the case. So you can see there that if you're in sales and retail or in cleaning, you're more likely to earn more money. And Rob Webster mentioned that this morning as well. He actually said that Amazon are pulling a lot of people away because they'll offer you £1,000 to join and work with them. So the care sector is competing against other industries to keep its staff. This has been mentioned previously by Laura, and I'm sure plenty of other people will mention it. I do not need to spend time on advising us all that the population is ageing, and we are going to see an increase in the older end of the population. And based on that growth, it is predicted that by 2035, we're going to need another 500,000 jobs in that sector. So let's think about the challenges around training, which is what I was asked to specifically consider. What training does this workforce already receive? More than half of the workforce do not hold a direct care qualification at level 2 or above. And the top chart there is what's referring to that. Of the 52% that do, 57% have engaged with the care certificate, and 77% have completed some element of training. Now, this data is collected by Skills for Care. What's interesting that is in the 15 standards in the care certificate, and also in the data that Skills for Care collect on training relating to skincare is not evident in either of those. And I've asked them that question, and they have confirmed that it is not included beyond the top 10 there even. There are some positives, however. We can see a bit of a light on the horizon. It feels like an insurmountable task to reach out and educate our carer workforce. But despite the vacancy rates, despite those turnover rates, 66% of recruitment does come from within the sector. So if they have left, they've probably moved to somewhere else within the sector rather than leaving care altogether. Now, it'd be interesting to see with the salary changes that I've mentioned, whether that will start to change. The NHS plan proposes a system working that will integrate social care, and the more recent enhanced health in care homes projects that are currently in play will also link NHS knowledge and support to provide improvement and training within care homes. But let's not forget that the largest portion of carers providing care are doing so in a person's own home setting. And no matter what you may think of this, and what doubts you may have, the government vote in Parliament, I think it was last week, for increasing national insurance contributions will see, we are promised, £5.4 billion going into social care over the next 3 years. And they've also quoted that they intend to promise more after that. Put my cynical hat away there. So how do we exactly reach out to this community of carers? Let's remind ourselves who they are. 82% of them are female, 65% of workers are aged between 25 and 54, 27% over 55. Now, I don't want to seem gender biased, but there are some assumptions that we can make about that workforce. Not only is this workforce in paid employment care for our family members, but they're also likely to be caring for their own children and elderly relatives as well. They're very busy people and some of the lowest paid individuals in the country. So we need to find ways to direct short and consistent messages to them. Over 95% of households do own a smartphone in England. So we can make some broad assumptions that the majority of carers will have access to a smartphone. However, the use amongst the over 55s drops off to about 2/3. They may also have access to the internet at work. So Cunningham et al. Have published papers on education in care homes. One of their papers is titled Understanding the Training and Education Needs of Home Care Workers, Supporting People with Dementia and Cancer. So they've only looked at them when they're looking after patients with those two groups of conditions. They've carried out a systematic review for that. And what they've been able to do is find some themes to barriers and facilitators to successful training. So as you can see here on this slide, we've got education and training, the delivery of that and the methods used, workforce motivation and resilience, and organisations, how supportive the learning is, what's the culture in that organisation. And they've been able to pick out amongst all of those things that can be deemed to be barriers or facilitators to providing effective training. So whilst we recognise nationally that the training of carers is very important and can actually lead to reduction in the need for admissions or healthcare support, it's still quite a challenge to achieve it. So these are some of the things they found. Largely what this slide is telling us, that actually what people valued or what was most effective was if that support and that education was face-to-face, collaborative, shared learning, provided opportunities to exchange ideas, and that they had direct contact with peers and senior colleagues to help them. Things that didn't work so well were looking at a training that just this is what we're going to do, and expecting it to fit everybody's needs. Things that were didactic, workbook things, DVD learning, and we could take that also possibly to mean online learning and e-learning. Things that might need to be read or require written responses. So those are just some of the examples that were also ineffective. And then things that facilitated learning and things that created barriers to learning were also quite evident. So facilitation things again involved that contact with other people, using experts and specialists to contribute to the training, getting service users themselves involved and contributing to that, and carers also. And then some of the barriers were quite practical things like distance to get to the training, how much it was going to afford they were going to have to spend to get there. Did they have low job satisfaction? What was their motivational level? And also this paper did consider dementia and cancer in particular. So there was the requirement around what they were given in terms of emotional support and dealing with end of life. Carers can get very attached to the people they're caring for, and they experience that loss, and that needed to be handled as well. However, there is still an overall lack of evidence regarding what constitutes effective and resilient education and training in this workforce. Nationally, we recognise that it's important to deliver that, but as yet, I don't think we've found the best way of addressing the challenges of actually achieving that delivery, particularly when we think about the challenges around the workforce themselves. So what TVS wanted to do was see if they could address this in some way. And so they put a proposal together to the trustees, wanted to develop a group of skincare champions who worked in home care or care homes. And their aim around this was to support home carers and care homes to provide excellence in skincare and to develop a network of carers who had some mutual interest in improving and delivering excellence in skincare. Despite Cunningham et al. Finding the need for human contact method learning to support effective learning, this project commenced during the pandemic. So it put face-to-face out of the window, really. And also, given the geographical scope of the participants, we've got some in Scotland, some down in Hampshire, face-to-face delivery and mentorship supervision from the Educator is not possible. So we commenced in May. I was interviewed, I had to apply, appointed as the skincare champion educator. And I've utilised a variety of methods to deliver education, but all of them do require access to the internet. They require attendance at a virtual monthly meeting and some element of reading, things that Cunningham have said don't work very well. So we've yet to establish how effective some of these methods are. We've had a 25% dropout rate. We had 12 organisations join. Only 50% of them have signed up to the Facebook group page, which is a closed group for them. And we have about a 33% attendance rate at the meetings. So 2 people have attended every meeting and a couple have attended 2/3 of the meetings, but we've got some that haven't attended any. We've provided them with ways to evaluate the programme. So we use a knowledge and skills and confidence questionnaire before each module. We've broken the programme down into modules. So and we've done one before the whole of the programme and one and after each module. I've asked them to write a story and we'll get them to write another one. But again, Cunningham found that those kind of things weren't effective. We will be asking them to review and evaluate the programme itself as we've reached our halfway point, and hopefully we can get some learning for them about some of the challenges that they have in actually accessing the resources. The resources get sent out via email, but we have got a closed page on the TVS page, and we put everything that we send out or we use in the meetings on that page, so people can access them later on if they need to or they weren't able to access the meetings. And anything we do like meetings is videoed and they can also go back to look at that. So, we're using a sort of dripping tap method of educational delivery at the moment, but it really is just a little drop in the big ocean that we need to reach out there for carers. The pilot system the program was funded by the Tissue Viability Society trustees doing a lot of walking last year when the pandemic hit. I think I got to learn my area. I found areas that I had no idea existed in my local area at all. And we raised some money to launch the pilot. And then we were very pleased to be awarded the Ergo Foundation Award, which will fund us being able to roll this program out to a wider audience as well. So we've started to plant that seed, and we're hoping that seed will grow. And with us evaluating things along the way, we'll be able to tweak and hopefully find systems that help to reach the carers that do sign up to this programme. So I thank you for listening. I need to stop sharing, I think. There are some references on this that people will be able to access after the presentation. And I think we can, I'm just checking how much time we've got, 4 minutes. So I think we've got time for maybe a couple of questions. Vicky, are you moderating some of the questions?
Yeah, there's just there's some we've put some links for some documents that people have asked for from Dimitri's presentation. I think Laura's been very kindly putting some great comments in as well. I'm just trying to look down into the comments, into the questions box now.
Yeah, I had some questions for Laura actually, and I know I've probably got a lot of time, but I wondered how you mentioned a QI project on patient and carer education that you were developing. I just wondered how that was going, if you've started it.
Yes, yeah, we have actually. So we're redevising our pressure ulcer prevention leaflet. So what we're doing is trying to make it more of a pathway, an interactive pathway. So instead of just having information for the patient, we're actually personalising it. So are you at risk? And then why am I at risk? And then what is my skincare advice? And we can actually document on that and use it. Carers can pick it up and see the advice we've provided. And we're currently trialling in one of our community hubs with some patients. So the healthcare assistant will go out after the first contact visit, spend 40 minutes with the care staff, with the patient, and actually have a cup of tea and sit down and talk to patients about their skincare and about their risk. And so far, we've got some really good feedback from patients, really making a difference.
Okay, I think that's some of your comments in the chat there, Laura, that it really is truly a collaborative approach that you've done here with your initiatives, isn't it? From patient engagement to the wider collaborative team as well. Yeah, it's fantastic.
I think somebody during Dimitri's talk mentioned anti-friction products to use. So I've not used anti-friction products for reduction of intertrigo, but there are some wicking products available now that you can purchase that are designed specially to lay in the skin folds to support with that. And I've used anti-friction products quite useful. Found those quite useful when you have got somebody who's got hypermobility, for instance, maybe their feet are moving on the bed or they shuffle their bottoms around. I
think that was a good comment, Heidi, as well, about just getting ladies to wear, a bra to support and lift the breast. I mean, simple but very effective, isn't it?
Yeah.
To minimise the risk of intertrigo there.
Exactly. It seems to be when you get admitted to hospital, the bra gets thrown out the window, doesn't it?
That's right.
Never to be seen until you get home again.
Yeah,
and we think actually we forget how useful they can be to prevent that sweatiness. Yeah.
Absolutely, that's right.
So you answered the question about professions, Laura, in the chat that somebody asked. So I think we're at the end of our time slot now. So thank you all for joining us and listening. I hope you've enjoyed that session, looking at the challenges of skin integrity in the elderly. Please do visit the 3M stand and all the other conference stands that are available tomorrow. And hopefully, I think we're the last ones today, so we can all go and have a good drink now.
Yeah, and thank you on behalf of 3M. Just thank you to Heidi and Laura and Dimitri for real insightful sessions. We've really enjoyed it, and yeah, we look forward end of the conference day one, and look forward to see everybody tomorrow. So thank you very much, both of you. Really enjoyed the session.
Thank you, Laura. Thank you, Vicky.
Thank you, and to Pink for making it all happen behind the scenes.
Oh yes, definitely.
The engine room.
Yeah.
Thank you. Good